Hello everyone, welcome back again. This is Dr. Hola Razouk, and today's lecture is about a very important neonatal condition, hemolytic disease of the newborn, also known as erythroblastosis fetalis. This is caused when the maternal antibody will destroy the fetal red blood cells, leading to hemolysis, anemia, jaundice. There are two main types you must know. The first one is Rh incompatibility, and the second one is ABO incompatibility. So let's start with Rh. What is it? It is when the mother, an Rh negative mother, carries an Rh positive fetus. How does it happen? Normally, the fetal and maternal red blood do not mix together because there is a placental barrier that separates them. So once the fetal blood and the maternal blood mix together, maybe during delivery most commonly, or miscarriage, the mother immune system will recognize the Rh antigen as a foreign substance, so she will become synthesized, hence the process sensitization. This means that the mother has produced antibodies against the Rh antigen. Mother will first produce IgM, then will produce IgG antibodies. The IgM antibodies cannot cross the placenta. Since it cannot cross the placenta, there will be no harm in the first pregnancy. However, in the subsequent pregnancy, if a fetus is born with an Rh positive blood group, then the IgG entity will be able to cross the placenta and will attack the fetal red blood cells. So hemolysis of the newborn will occur. Hemolysis will lead to different symptoms, including anemia. If anemia is persistent, jaundice will occur, mainly the indirect or unconjugated bilirubin. Erythroblastosis fetalis is seen. This is a feared outcome. Immature red blood cells in the fetal circulation, high output heart failure. Also, high output heart failure can lead to hydrops fetalis, which is a life-threatening condition combined with edema or ascites or fluid accumulation in the pleura or pericardium. How can we prevent Rh? This is very, very high yield to know. We give ROGAM, RHOD immune globulin. This is a passive immunization. When do we give it? We will give it at 28 weeks of gestation. This is routine prophylaxis, so every pregnant woman must receive ROGAM at 28 weeks. If the baby is confirmed to be Rh positive, then we have to give it within 72 hours postpartum. How do we treat it? We will give intrauterine transfusion for severe anemia. After birth, phototherapy to treat the jaundice, and the exchange transfusion in severe cases. That's all about Rh incompatibility. Now let's move and talk about ABO incompatibility. This is when the mother has a blood type O and the fetus is either A, B, or AB. In ABO incompatibility, the mother has already antibodies against the blood type A, B, or AB. She has naturally occurring IgG anti-A or B antibodies. Unlike Rh incompatibility, there is no harm in the first pregnancy, because if you remember, in the Rh incompatibility, we said that the mother is synthesized during the first pregnancy, so she will produce Rh antibodies, so she will be affected in the following pregnancies. Because there is naturally occurring IgG, anti-A, and or B antibodies, they can easily cross the placenta and affect and attack the fetal red blood cells. So hemolysis will occur. Jaundice can be seen within the 24 hours. Anemia can be seen, but usually it is milder. There is no hydrops fetalis. Treatment will be phototherapy or exchange transfusion in severe conditions. So to summarize, RH is more severe than ABO. There is no harm in the first pregnancy because the mother is synthesized. It can affect the future pregnancy, as we said, because the IgG antibodies will be able to cross the placenta, and it will cause hydrops fetalis. ABO is usually milder. It affects the first pregnancy because there is naturally occurring antibodies against blood type A or B of the fetus, and no hydrops fetalis is seen. If you find this lecture helpful, please like, comment, share, and subscribe. See you in the next lecture. Thank you for listening.